Various biological factors influence outcome in brain injury. For example, the status of brain structures and functions, previous brain injuries, age, prescription medication effects, both benefits and side effects, illicit drug and alcohol use, seizures, fluid collections inside the head, metabolic or hormone imbalance, and infection inside or outside the central nervous system. When considering psychological factors, I try to keep in mind the following. It's not only what happens to us, but how we interpret it and how we respond to it. Our psychological vulnerability to brain injury relates to past experiences and development, as well as current psychological resources. We evaluate the present in terms of our internal psychological conflicts, relationships, and goals. Brain injury and the varying degrees of dependency, loss of control, and incapacity lead to regression, that is, revival of earlier, more childlike ways of thinking, feeling, and relating to others. These are often more primitive and less reality-oriented. When healthy, we're aware of these regressive attitudes, but they are reactivated and intensified under the stress of brain injury. The regression caused by the brain injury reactivates certain universal fears, as described by consultation liaison psychiatrists James Strain, MD, and Stanley Grossman, MD. And these fears are similar to those that we experienced earlier stages in our development. The ability to adapt to current worries and stresses depends on how adequately we adapted to these stresses when we experienced them as a child. The predominant fears, internal conflicts, and their degree of resolution depends on our early life experiences. For example, the nature of our relationships with parents and other caretakers. Brain injury is always followed by loss of self-esteem and unpleasant feelings. For example, depression, anxiety, guilt, shame, helplessness, and powerlessness. While those of us who as children were not neglected, hurt, or exposed to extreme emotional or physical traumas, and whose relationships with parents was built on trust, are less likely to be affected by the fears, losses, and painful feelings of their current disability. For example, a good early childhood relationship with mother allows us to have basic trust in our caregivers. A good early relationship with father leads to our ability to trust men, allow ourselves to be passive in relationships with men, for example, comply with recommendations of male healthcare providers, caretakers, and to respond to authority without fears of being weak.